Hi, everyone. Thank you all for joining us. I'm Dr. Nayyer. This is Dr. Jamshed.
Hi.
We're both part of the internal medicine department at Englewood Hospital. So I'm sure all of you know why we're here. Some of you might have been diagnosed with arthritis. Some of you might think you have arthritis. You have the signs of it, but you're not quite sure. So you're here to kind of find out more and learn more about it. So this talk primarily is going to focus on the aspects that we can kind of change and modify to kind of help you live with arthritis. So it's going to focus primarily on food, nutrition, and then exercises that you can do at home, which means that you're not going to require a lot of equipment. You're not going to require a lot of things to go outside. It's going to be things that are easy to do and things that are manageable on a day-to-day basis. Okay, so I guess before we kind of delve into it a little bit more, I want to talk about just the basics of what arthritis is. Sorry, let me see why this isn't pulling up. Do you want to ask her to see what's happening?
This is fine.
It's fine there?
Yeah.
Okay. All right. So kind of being just, we're going to go systematically talk about what arthritis is first. I'm sorry about the presentation. We'll try fixing it in a bit. But just talking about what arthritis is in general. So we're going to focus on what osteoarthritis is. So I'm sure most of you have heard that it's something that affects the big joints of your body, right? You might primarily have heard that it's something that's affecting your knees, your hips, your elbows, and then your fingers. And you might be wondering, hey, which kind of arthritis do I have? I'm not sure, right? Because there's multiple different types. When someone says arthritis, it's a very broad category. There's osteoarthritis, there's rheumatoid arthritis, there's psoriatic arthritis, and then there's something called seronegative arthritis. The ones that we're going to focus on today is osteoarthritis, which is the most common. This might be something that might be shocking to a lot of you, but more than 60% of individuals are going to be living with arthritis after the age of 65.
This includes both men and
women.
If you can make it like a PowerPoint full version.
It's also one of the most common causes of debilitating diseases in the world, but especially here in the United States. So that means that someone's living with arthritis chronically. They might know they have it, they might not know they have it. But it's one of the most common diseases to have. And it's something that is chronic, meaning that you're going to be living with it, which is why it's very important that you have to learn how to manage it, okay? When we talk about who's more affected by it, so there is a higher propensity for women to be affected more than men. It's going to increase your risk as you grow older. So mostly when you're above 60 to 65 is when you start having these symptoms of it. And it's something that has risk factors associated with it, meaning that there are things that could be increasing your chances of having this disease. So primarily, like I said, it's gender. So if you're a female, you are at a higher risk of having it, unfortunately. The other very big one is obesity. So as we know, this is something that is affecting our joints. So the more weight that is being placed on our joints, the more chances of these joints having wear and tear. And as you age, they start just rubbing against each other, and we'll go into what it is in a bit, and that causes this condition to worsen further, okay? Something else that you might kind of think about, which is intuitive, is that if you've had some kind of injury to your joints in the past, that means that your joints now, as you grow older, they're going to feel that effect later on. So that means if you've had any kind of injury when you were younger, maybe a car accident, anything that involves your joints, okay? And then anyone who's living with chronic diseases like diabetes, like gout, even if you have rheumatoid arthritis, all of these things are now adding on. So we've talked a little bit about what causes arthritis, who are the people who are more prone to it, what the risk factors are, but what is osteoarthritis really, right? That's the essence of this entire disease. So if you can imagine, these are your two joints, and so here's your ligament, which is kind of keeping your joints in place, and here's your joint. Now normally you'd want to have a distance of at least this much in between my two fists. As this joint disease progresses, the distance becomes less and less and less to the point where there's no distance left anymore. Okay, this is when it starts rubbing against each other. So a lot of you, when you walk, maybe you felt a clicking, or maybe you felt some kind of like joint effusion, what we call it, or some sensation that's different, and you feel pain when you walk. That's because the joints have kind of grated against each other so much that they're causing this friction now. So that every time you walk, you feel that way. And it isn't necessarily just for your knees. It could be, like I said, it could be in your elbows, it could be in your hips, it could be in the small fingers of your hands. But all of these things are kind of causing the wear and tear as you grow up, okay? You might be wondering, well, if this is something that I can't prevent, what can I really do about it? And that's where we're going to talk about what you can do in terms of the manageable risk factors. So, like I said, it's one of the most top causes of disability in older adults, which is very concerning because usually you'll hear diabetes, you'll hear hypertension, you'll hear all of these different diseases that people might be more familiar with, but the one that we don't really talk about much, but it should be given as much emphasis, is arthritis, because that's something that you can feel. The diabetes, you might not know you have it because it doesn't cause any kind of disability as such. The same thing with hypertension. It's called a silent disease for a reason. But arthritis is something that you live with every single day. You feel the effects of it every single day, which is why we thought it was very important that we actually have this lecture today to kind of talk about it more. So like we talked about, it's very important that we kind of differentiate osteoarthritis from different kinds of joint pain, because not everything that's making you feel pain is directly linked to osteoarthritis. Now, what I mean by that is you might have other conditions that can be causing pain overall, but not necessarily that your joints are going through this thing, which is why it's important that you see a doctor to kind of get a good diagnosis and therefore be able to treat your condition. The next, like we talked about, of course, is the risk factors, right? So when you start feeling these symptoms, what are these symptoms? So if anyone over here would like to tell us what you've been feeling and if you think that is the source of your osteoarthritis. If someone can just across the room tell me what they feel. Sure.
Which you referred to before, is that called what they call bone on bone?
Absolutely.
Yeah, so you feel that.
Yeah.
And of course pain.
Yep.
And when the weather, when you precipitation, it's more, I don't know why.
Yep.
It's for that, but
yeah.
It's true, you feel your bones.
And when you say pain, what do you mean? What kind of pain would they feel?
Well, it's severe pain. When you have trouble walking.
Yeah.
Fingers, you know, you want to get some relief.
Yep.
It's a balm or a shot or something.
Yep.
It's severe pain.
And is it worse when you wake up in the morning? Is it worse as the day goes on? Is it something that you feel is the same throughout the day?
It's often worse in the morning.
Worse in the morning.
And for me, the symptoms are more like just like extreme stiffness.
Yes.
Real, like
Yes.
you can't move, or it takes a while, and then it warms up, and then you're
Yeah.
okay. But it starts out that way.
Exactly, and that's exactly what you said, right? So pain is one huge thing that everyone will feel, but stiffness is another one. And it's almost like you can't bend your fingers at a certain point, right? Because it's so stiff, you feel like you're kind of like stuck there. So yeah, so pain, stiffness, anything else that anyone has ever experienced? Achiness, yeah. So it's not really like a pain. It's more if there's like a deep ache in your bones that you can't really describe any other way. Anything else?
Swelling, inflammation.
Yes. Yes. Then that's the next big thing that we want to talk about, right? So you have pain, you have achiness, you have stiffness, but one of the most like alarming symptoms if someone could have is swelling. Because again, that could mean, and we'll talk about risk factor, like the alarm symptoms in a bit, but anyone who's having swelling and it's becoming hot and tender and swollen and not just swollen, that's something that's concerning, right? And that's something that's out of the ordinary. One thing that I really want to talk about, because it's not really mentioned here, but I think it's very pertinent to mention, You might say, hey, I want to get an x-ray done because I want to see whether I have this. Interestingly enough, a lot of people might have radiographic changes, meaning that on their x-ray, they might have signs of arthritis, but they might not have any symptoms of it. Okay, so what that means is, like I said, more than 60% of the population is going to have it at some point. It's more of a who's being affected by it versus who's not, right? Which is why your doctor might not necessarily rely on their x-ray and the diagnostic imaging too much, and they're going to ask you, like I'm asking you, what your signs are, what your symptoms are, how you're feeling, because that's really going to guide your therapy and your management plan. Okay.
What we mean by that is that osteoarthritis is a clinical diagnosis, and it doesn't necessarily require us to order imaging to make a definitive diagnosis. So if you're having signs or symptoms, as we spoke about, that's how we're going to diagnose it, and we're going to direct you towards therapy without needing an x-ray.
Okay. So, you know that there's a lot of conditions where you're going to go get a blood test and they're going to tell you, hey, your sugar's elevated on this blood test, therefore you have diabetes, and you have a diagnosis that way. Or like Dr. Jamshed is saying, there's a lot of things where you're getting imaging done, and that imaging is being definitive. It tells you, hey, this is exactly what you have. But there's certain conditions, especially rheumatoid, like bone diseases, which require a clinical diagnosis.
I have a question.
Sure.
For the knees, with an x-ray, you will be able to see that the cartilage is
Absolutely,
gone, right?
absolutely. There's many things you can see on the imaging. You can see that the cartilage is gone. You can see what we call spurs, meaning there's these small little things that start forming because there's so much friction. There's like a new kind of almost bone sticking out, like protruding out. You can see effusions, meaning fluid buildup around the joints. You can see many, many different things.
And decreased joint spacing,
Yeah.
as we spoke about, because
Like-
the bones are rubbing against each other.
So you can see all of those things for sure. But what I meant is there could be that if I do an x-ray of 100 people, there might be 40 people who have those signs, but they're not going to have the symptoms of the disease. And unless they have symptoms, we're not going to treat it because, like I said, a lot of people have it. But unless they're starting to get pain from it, it's not something that needs to be actively managed. Does that make sense? Okay. All right.
If you have the sign and no symptoms,
Yes.
does that mean that it's
Unfortunately, yes. Which is why we, are going to talk about just foods and exercises and things that we can do to prevent it. So like we talked about, the preventable modifiable risk factors, which is what we're going to dive into, to make sure that no one has to have a debilitating disease from it. Okay? Sure.
Yeah, so a year ago I broke my wrist,
Mm-hmm.
and I notice now, like sometimes in the morning it's stiff.
Yeah.
So that's pretty much what it is.
Oh, yeah.
Okay.
Yeah. And if you see x-rays, a lot of times it'll say arthritic changes noted. But you might be feeling, okay, but I feel okay, but this is what it says on my x-ray. And that's another part of when you go in for some other kind of imaging and you see those test results, that's all it means. Just for us to know that there's something going on in your bones, well, your joints.
Yeah, and a few years ago I was walking up the steps, and all of a sudden I felt like something just came apart.
Ooh,
on my knees.
like a popping sensation
Right.
almost?
And then after that I started having pain if I'm going up the stairs. But it doesn't affect me if stairs are too cold. If it's too cold, I'm fine.
Right,
And I don't feel it. But it's when it's not too cold that I feel it.
right.
So that's pretty much the same thing.
Pretty much, yeah. Okay, so one more thing I wanted to mention. So for blood tests, so your doctor is going to order blood tests. These are more so to rule out other conditions, other arthritises. Remember, rheumatoid arthritis is something that you can see on blood tests. There's specific antibodies, there's specific tests that we do to rule out rheumatoid arthritis. Once that is ruled out and the symptoms that you have are aligning with osteoarthritis, then only are you given an official diagnosis of osteoarthritis. That's very important for you to understand, is I don't want you guys to take away from this point that we don't do blood tests. We absolutely will do them. We're going to look for inflammation markers. We're going to look for different antibodies to see if there's anything that's causing your pain to be related to a certain disease. And once that's ruled out, then your diagnosis will be given as osteoarthritis. Okay? So you might get imaging done, you might get lab tests done, but it's just to make sure that other things are being ruled out, not in. Okay? Let's talk about management. So who's tried what and what's worked and what hasn't worked so far?
Exercise, movement seems to help.
I'm glad.
The more you move, actually, the better it is.
For sure. We're going to speak about that in a lot of detail. We're going to demonstrate some exercises. We'll dive deeper into it, but absolutely, that helps. It helps with the stiffness, helps with better movement. But the important point is not to do it when you have an active flare of it. The good point is to prevent it, to just keep it at bay and having regular physical activity and movement in order to not get that pain, that severe pain in the first place. Because when you have the severe pain, exercising would be of limited help at that point. Okay.
And one very interesting fact that I read was if you lose just 1 pound, the effect on your joints is as if you've lost 10 pounds. And so that is a massive thing to remember.
Yeah, I see a lot of people at the track now, they're using weight vests.
Yes.
Long term, is that good for?
No. The short answer is no. And the reason for that is the way that your spine is feeling this pressure. So what a weight vest is doing is it's making you add on more weight as you walk, climb, run, whatever, right? So in the short term, because there's more stress on the body and the bones, it might lead to some weight loss. But in the long term, what's happening is that there's so much pressure, especially on your back, that it might cause like severe debilitation as you like go on. And one of the biggest things that can happen is that you might hear people say, oh, I popped my back. What that means is that a part of your like spine, a part of the little cord, if you will, kind of bulges out. So there's actually a lot of studies that have been done on it. This is more of a, what we call an exercise fad, meaning it's something that's become fashionable, but it's not something that necessarily in the long term is giving people the benefits that they require. And again, your goal should always be to have like long-term, prevention, as opposed to a quick 10-day, you feel great and then something's going on in your body, right? It's the same thing that we advocate for weight loss as well. And it's the same thing that we advocate for exercise, as we're always looking for long-term solutions. So you said that exercise helped you. What else in terms of?
What about Tylenol for arthritis?
Yes.
And the other thing, like those knee pads.
Yes. Knee pads as in the heating ones, or just wearing them?
Wearing them when you exercise.
Okay. So let's talk about the medication that you can use that is safe, that has been well studied, and that's backed up by evidence. Okay. So what is your goal when you're trying to take all of this medication? Well, number one, you want to reduce your pain. So you're working on pain receptors. Number two, you're working on inflammation, because remember, like I said, there's so much like grinding going on. It's causing a lot of stress. It's causing a lot of inflammation on your body, right? So absolutely, you can take Tylenol, no problem. You can take it, once, twice a day. The recommended dosage is 4 grams in 24 hours. What that means is you need to be careful and you can't overdo it, because again, remember, something even as mild as Tylenol has a side effects, okay? People can go into like liver damage just from taking too much Tylenol, so you don't want to do that. You always want to take it in safe doses as on the label, because it's an over-the-counter medication. The other thing that you can do is, again, like Dr. Jamshed was saying, so when you're having an acute flare, you want to take something that's warm. So you want to use warm compressors at that point, but this is when you're having active pain. But before you have any onset of that, you want to use something cold. And the reason for that is the cold is going to help with your inflammation. It's going to help the swelling go down. Okay, so cold means something like you can do cold, the freezer packs, or you can do icy hot. Anything that's over the counter, it's safe and it's effective as well. So remember, you want to do cold for inflammation before you're having an active flare, and you want to do hot when it's really, really hurting you, because that's going to help you give calmness to your joints at that time. Okay?
Now you said cold is before you have it. I mean, if I'm sitting there and everything is fine,
Yeah.
I don't have to use, do I use the coldest then?
So for example, if day to day you feel like your pain is worse at night, that's when you're really using your warm compresses, okay? Because that's when your inflammation is at its peak and you want to kind of make that go down with the warm compress. However, if you feel like you're somewhere midday, you kind of start to feel the ache come on, but it's not quite as bad yet, you want to use your cool compresses. And you can use cold compresses throughout the day. You can use them daily. Again, like I said, there's no real harm to it, and it's something that's well tolerated by most people. So if you feel like your hips ache, place it there. You'll feel better. Get it from any CVS, Walgreens, and then when you feel like, oh man, this is really bad and I need to take something for it, that's when you start using your warm compresses as well, in addition, of course, to your medications.
One thing I want to add here is that everyone is different. Our bodies are different. Our levels of arthritis is different. Our pains are different. For some people, from what we have heard from patients, for some people, the heat works better than the cold. So just do, if you're unsure, always do a trial of what works better for you.
Yeah.
The heat usually helps with the stiffness that you feel, as the achiness and the stiffness, and the cold will help lower down that inflammation that's going on. So just trial what works better for you. For some people, it might not be the case. For some people, cold might work better than heat. That's what we've been hearing, different things. But what Dr. Nayyer said is a rule of thumb, but for you, it might be different.
Yeah.
Okay.
Yeah, that's actually a very, very good point. Oh yeah.
Or all those creams.
Yes, I was just going to talk about that. So the ones that are effectively going to work are the Voltarel gels. And you can use them up to 3 to 4 times a day. And just make sure that it's something that is not absorbed in your body systemically, meaning that you might have heard that there's aspirin, there's Aleve, ibuprofen, all of these things. All of these things are potential blood thinners as well, meaning that they can cause significant bleeding in your stomach, and they can lower your blood counts further if you're already on a blood thinner medication on the side. So what we recommend instead is that you're taking your Tylenol, which you're doing, and in addition to that, you're taking these gels. So if you look at the label, it's either going to say diclofenac sodium, which is an NSAID, or it's going to say Voltarel gel.
It's Voltaren. So a Voltaren gel. Voltaren gel, that's 1%.
Yes.
Diclofenac sodium.
Yes.
Yeah. You can use it safely up to 4 times a day.
Yeah.
So every 6 hours. It's been shown that the effect of it, if you use it as directed, up to 4 times a day, can be almost as good as just taking an oral pill, like an oral NSAID. So that's something which is very underutilized. Patients usually say, oh, it doesn't really help, but they're not using it. It's very easy to pop a pill every 6 hours, but it's not as easy to apply the gel every 6 hours. So that's something that makes a difference. Yes, please.
So for the Voltaren gel, I read that you should take it with some oral medications, I can't remember which one.
We cannot take it with oral medications?
You shouldn't, mix the two.
Yes. Yeah. So that's what.
Does that mean that then it kind of gets absorbed by the
Yes. So that's what we're saying, right? It's not as much. The systemic absorption is not as much. So what that means is, if you see any doctor, they're going to tell you be very careful when you're taking an NSAID, right? When you're taking a Aleve or ibuprofen, and never take it on an empty stomach. So that part is coming in because it has a very significant profile in causing GI, like stomach bleeds, ulcers, and it's something that we always tell our patients to use with caution. The gels, the good thing about them is even if you have all of this risk profile, because there's very, very limited systemic absorption, it means that where you're applying it, for the most part, that's where the effects are being felt. However, like I said, so you can take your Tylenol and you can apply your gel with it, and the two combinations are fine. But you do need to be careful, yes, and thank you for pointing that out. You do need to be careful if you're taking two NSAIDs together at the same time.
So don't take an ibuprofen and Voltaren gel like together multiple times a day is what we mean. But Tylenol with Voltaren gel, that combination is ideal and is really what we recommend.
Yeah.
Okay, but if you are not on any blood thinners, no risk factors, you're having an active flare, then I would recommend to take ibuprofen or other NSAIDs for 3 to 4 days every 8 hours just to get rid of that flare. And once that flare is gone, just resort to your Voltaren gel and Tylenol again. Just don't take your NSAIDs for a prolonged period of time is what the point is basically.
Yeah, but thank you. That was a very good point that you brought up. Other things. So this is all medications that you can take over the counter. There are some medications that your doctor is going to be able to prescribe as well. So that's in the range of your SNRIs, which is something called Cymbalta. It's used for many different things in medicine, but it's also used for people who have arthritis. And it's been shown that it is equally as helpful in decreasing the pain and the inflammation that's caused by it in people who aren't able to take other medications. You might have heard your doctor talking to you about taking shots, intra-articular joint injections. Now, usually these are steroid injections that you take. You can get one shot usually every 3 months, and that should be able to help with the pain. Now again, remember everything comes with a caveat. So for example, if someone has a lot of risk factors that the doctor feels is unsafe for them to have a high dose steroid, then they might not be recommended to get one. But depending on your severity level, depending on how much discomfort, disability you're feeling, it is something that is commonly given, generally very well tolerated, safe. It's not really painful. They're going to numb it. They're going to give you the shot, and then that's it. So it's not something that's like a procedure or it's a big deal. You don't need any kind of anesthesia for it. It's just a shot that you get. Has anyone gotten one of these before? You have. And how did it work? How did it work for you? It worked well. Yes. So yes, that's exactly what I was going to say. Have you felt the same way?
I don't like the injections. I feel that very painful.
Yeah.
And they don't last.
Yeah.
Any time at all.
So that's exactly what the problem is. And there's actually studies that say that as you get more of these injections, the effects of them are felt less and less and less. Meaning it's not something that is routinely given or prescribed because you're going to start, getting used to it, so you're not going to feel the effects as strongly. So those are some of the things that you can do. So I think the most important thing really to focus on is trying to keep up with the pain before it gets so bad that you kind of come to this stage where you have to do all of these things. Of course, if it's really bad, you've had imaging done, there are 2 other things that are surgical that can be done. One is something which the orthopedic surgeon is going to go in. It's not really a big surgery. It's more of them really going through your cartilage and taking out whatever inflammation or those spurs that have been formed, osteophytes they're called, and they're going to remove them, okay? Or you might be asked to go for a hip repair, a knee repair surgery, where they kind of go in and they they remove the knees or the hip areas.
Like knee replacement or hip replacement.
That are their affected joints and they give you something else in return. Usually, you know, there's different kinds of hip replacements that they do. So you'd be able to discuss that further with your surgeon, but these are always last resort options. It's something that we would potentially want to avoid if we can, but it's still something that, you know, is part of life. So what I'm trying to say is that there's always a solution to your problem. It just depends on how severe or debilitating it's getting. But there are surgical management options as well for osteoarthritis, not for any other arthritis, including rheumatoid or whatever, because that's just medication management.
One thing I wanted to add regarding and then I'll listen to your question, regarding the steroid injections. So they work miraculously in the short term, but over time, if you take them too much, they can cause thinning out of the cartilage. So they can actually make the arthritis worse in the long run. So unless you really, really need a shot and it's, you know, you're not getting relief by any other method, you should definitely get it. Otherwise, try to avoid it. Okay. And then I think you still have to talk about the warning signs, right? Mm-hmm. Okay. What's your question?
Yeah, my question was, is there one type of arthritis that's more dangerous per se than the other?
That's a good question. So it depends on what your definition of more dangerous is, right?
Life-threatening.
Right, life-threatening. So I wouldn't necessarily say that osteoarthritis is life-threatening. In a way, it's not a systemic disease, meaning it's not affecting different organs of your body. There are arthritises, like I mentioned before, so your rheumatoid arthritis, psoriatic arthritis, seronegative arthritis. There's different arthritises that affect younger people. All of these are systemic, meaning they're affecting your brain, your heart, your lungs, your kidneys, and then your joints. And these are severe enough that they can land you in the hospital for different kinds of reasons, for different infections. These are severe enough that you need to take what we call immune modulating therapy, meaning that it's very, very strong, powerful, prescribed medications, infusions, shots that they have to be on forever, because it's a disease that they're going to have for the rest of their life. And unlike osteoarthritis, which you can still kind of fix in the sense that if it comes to it, you can have replacements done of different parts of your joints. Rheumatoid arthritis or these different arthritises kind of don't have that. So do we see more patients being admitted to our inpatient hospital? Yes. And are those for osteoarthritis? No. They're for different arthritises that are unfortunately affecting their kidneys. So now there's issues in the kidneys or the lungs, and now they have issues with the lungs, and then they're here for flare-ups of that. But that's a good question.
So you're saying you can get arthritis in any part of your body?
Oh yeah. No. So the arthritis part is staying in your joint, right? But because it's a whole autoimmune condition, like the rheumatoid arthritis, for example, it's the circulating antibodies that are going and depositing everywhere else in your body as well, in a way. So that means that it can affect a lot of different parts of my body, not necessarily just my knees or my hands. So that's why it can cause different kinds of like syndromes and conditions that people need very, very strong medication to kind of keep them subsided.
The name can be misleading for like normal people. Oh, it's rheumatoid arthritis, so you know it has to do with the joints, but it's actually a bigger disorder than that. Mm-hmm. But the name is definitely confusing, so it's easy to confuse. It's just involving the joints, but it's actually involving other organs. But with osteoarthritis, osteo means bone, right? Arthritis means inflammation of the bone, so it is staying within the joints. Okay.
Yeah, one other question. In terms of medicine again.
Sure.
I'm noticing that you see now a lot of rapid release pills. It's a capsule, and inside it has the little pieces and rapid release. Is rapid release better than using just a regular capsule, medication?
So rapid release is just a way that your body is absorbing the medication, which means that if, for example, a regular pill will take, let's say, 40 to 50 minutes to work, the rapid release per se should take like 15 or 20 minutes to work faster, but it's going to give you the same kind of result in the end.
It's the formulation of the pill.
Yeah,
if
that's
it's
all
in the
it is.
form of a capsule, that may be better or like quickly absorbed into the bloodstream rather than the other pill formulation. But at the end of the day, the effect would be the same. It's just how quicker you're going to get the relief.
Yeah.
Okay. Speak about red flag.
Sure.
Now, you mentioned earlier about it feels like it's swollen.
Yes.
I've had that experience in my arm. It feels
Yes.
like it's swollen, but it's not.
Right.
What's going on there?
Same thing. So, like I said, any part of your body can have like this swelling. It's basically just inflammation that's building up. So sometimes people can actually have like these big like bone protrusions coming out as well, which might look very concerning, but it's just your like the deposits of all of this inflammation coming together. So you can have the swelling. It might not necessarily be painful. It might not necessarily be tender, but you can feel like a lump there.
But definitely if you ever have a joint swelling, which you think it's like erythematous or it's like red, it's painful, it's a little bit, if you touch it, it seems like, there could be some fluid inside it. Those are like alarm symptoms. And that could mean, especially if you present with, you may be having a little bit of a fever as well, it could be a sign of an infection of the joint. So whenever in doubt, always get it evaluated. All right?
Yeah.
Yeah, so my brother-in-law has that protrusion like you talked
Yep.
about.
Mm-hmm.
So does he have that for life, or can something be done so it goes away?
Right. So just like with anything else in medicine, there's what we call differential diagnosis, meaning that there could be multiple different reasons why he has it. One very common one is called tophi from gout. Now, gout is a completely different condition, but it kind of deposits the same way. The other is if you have something called oligocrinone bursitis, which means that you're using this so much, so frequently, that now you're kind of getting a protrusion out more than anyone else would. Or it could be from osteoarthritis. What can be done? So for the most part, from what I've seen, if it's from gout, you're going to have it. Because of the way that the deposits have kind of formed, it's going to stay there. If it's from some kind of bursitis, meaning there's temporary inflammation going on, it can be reduced with time, with like hot compresses, therapy, all of that. If it's from osteoarthritis, for the most part, no, it's not really going to go away because that's the new structure that's kind of developed. But if it's something that's cosmetic and they want to have fixed, then that's a separate thing. But from what I've seen, usually no, it doesn't really go away. And then the last is if someone has kidney disease, it can also present in different ways and they can have like these bony depositions, if you will. So, sorry, I don't know if I could answer that, but so I'm sorry, this presentation, it works and then the screen just starts acting up. But yeah, we were going to discuss next when to really go to the doctor. Now, you might have a diagnosis of osteoarthritis. You might think you have osteoarthritis, but either way, you're, for the most part, being able to manage it and you're living your life and your pain's kind of under control, and suddenly you wake up one day and you feel like you have a very hot, swollen, tender joint. It could be anywhere in your body. It could be in your finger. It could be in your elbow. It could be in your knees. And like Dr. Jamshed said, you take your temperature. Anything more than 100.4 is what we classify as a medical fever. Anything less than 100.4, we don't really classify as fever. Okay? So if you take a temperature and you feel like you have the fever, you have this new swollen joint that you haven't had previously, that's something that we said we want to make sure there's no infection going on there. Okay? If it's very tender, if you're waking up and you feel like you have more restrictive movement than normal. So normally if you could move your arm with a little bit of pain and now you can't really move it at all. Similar when you're walking and now you're having a really hard time walking all of a sudden. All of these are alarm symptoms. If your knee suddenly feels like it looks very, very red and tender, you want to make sure there's no other cause that's causing all of this pain, because there's a lot of different kinds of infections that could be going around in the body without us knowing. It could be as simple as you getting a microscopic cut and that causing a lot of inflammation and infection as well. So because of that, we always recommend that you call your doctor up or you go and you have it evaluated, because it's better to be safe than sorry. These are some of the things that we would say are like absolutes. The rest is, if you feel like your symptoms are getting worse than what is commonly manageable by you, then that might be another discussion like we talked about. Is this now at the stage where you want to go and you want to have surgical options considered? Then you need a referral to your surgeon, and that's another process that has to happen. So if you start feeling your symptoms aren't manageable anymore, that's another reason for you to go get checked out by your doctor, okay? Another thing to mention that's very important is sometimes osteoarthritis goes hand in hand with rheumatoid arthritis, meaning that you can have both of them presenting at the same time. You might have some symptoms that are from rheumatoid arthritis. You might have some symptoms that are from osteoarthritis. And your doctor is the one who's going to be able to order the right blood test to come up with this final diagnosis. So some people are going to be living with both conditions at the same time. And that's, again, very, very important, because the treatment is different for both. So I don't want you guys to feel like, okay, I have this pain in my joints and this is just the way that I live my life. I would recommend you go and you have it tested, because you want to make sure you're taking the right medication. We have medical management for a lot of different diseases, especially these that are controllable diseases, meaning that you can live with them and you can feel like your symptoms are managed. So it's very important that you have it checked out, even if you have an inkling that there's something else that's going on, because you know your body's best. Okay?
Can damage to your rotator cuff present itself as arthritis?
So in the long term, you mean if you've had injury in the past, or do you mean like a sudden?
Like sudden.
So it wouldn't necessarily present as arthritis, but you would have a lot of overlapping symptoms. The biggest difference that you would feel if it's a true tear versus not is you would have weakness. With arthritis, you might have a lot of things, but you're not going to have weakness, as in you can't move your arm because you feel weak as opposed to it being pain. And just the way it's positional, you might have pulled something, you might have fallen, had an accident. There's going to be some kind of precipitating factor that's going to make you feel like there's a difference.
With rotator cuff injury, usually like if you move your arm above 90 degrees, the pain gets really bad. It gets really worse than it is. So that's one of the signs you can also see, so the rotator cuff tendonitis versus an osteoarthritis.
Yeah.
All right. For the purposes of lack of time, because we're short on time, we're going to keep the questions to the end. And I would quickly want to talk about foods that we can eat in order to prevent osteoarthritis. And also I would ask one of you to be a volunteer for me, because we want to demonstrate some of the exercises that would be arthritis friendly. All right. So with foods, so a long time ago it was thought that osteoarthritis is a wear and tear disease. But with more and more studies coming out, it is hypothesized that it's also has to do with some level of inflammation, which is why we do recommend an anti-inflammatory diet for arthritis. You might have heard of like diets for hypertension. You should eat a low salt diet, a Mediterranean diet. For diabetes, low carbohydrate diet. But for arthritis, diet does help, especially in preventing those severe episodes of, flares. So the anti-inflammatory foods that could help arthritis are nuts, seeds, high quality oils like olive oil, especially the extra virgin olive oil, avocado oil. Dark chocolate is great. I mean, obviously, little quantity in moderation. Fruits, specifically the berries, they're very good. They help with any oxidative stress on the joint, any inflammation. So blueberries, raspberries, strawberries, any kind of berries, really. And eating a diet that's high in like green leafy vegetables. So your salads, those are beneficial. And then at the same time, avoiding inflammatory foods. So these would include our processed foods, anything that's canned, jarred, even your pasta sauce that you're putting in your pasta, carbohydrates. Those kinds of things you should try to avoid. Fried foods, all of these can cause more inflammation. And it's really a matter of combining diet and exercise in order to keep your symptoms at bay. We did speak a lot about, what if you get the pain, and what should you do in those scenarios, which had both conservative and the drug treatments. But diet and exercise are really the foundation of how to keep your symptoms at bay. Okay? So this was the diet aspect. So the three most common kinds of osteoarthritis that we see are really in the hip joint, the knee joint, and the small joints of your fingers. So those are the three that I want to focus on in terms of exercises. We can start with the fingers first. I can demonstrate that myself, and then later I'll ask one of you to come up for the other exercises. So really for the hand, there are three major exercises. They are in the brochure. I'm sorry it's like printed a little bit off. I'm not sure why, but you can turn around the page however you like and see those exercises. The three that I want to talk about more are the finger bent, the finger stretch, and the grip strength. So the finger bent is really, there are three joints in your hand. This joint, so they have fancy names. Metacarpophalangeal joint, you don't need to know these names. Proximal interphalangeal joint and distal interphalangeal joints, blah, blah, blah. But it's 1, 2, and 3, okay? So it's really targeting these two joints for the finger bent. So you're gonna have your hand stretched out like this and bent these two joints. So this is being bent and this is being bent, and this stays straight. So it's really like this. And then pull it out. Again, do that bent. Pull it out. So repeating that like 10 times and in 2 to 3 sets, 3 to 4 times a week, would really help with the workout of the muscles. Remember, every joint needs workout, even your hands. So they're going to get stiff with age, with wear and tear, and our diets, we all know how our diets are. I'm no saint, but we all can do better, okay? So this is the finger bent exercise, and then there's something called a finger stretch, which is a little bit easier. You lay your palm on the table, and you support your wrist with your other hand like this, just to keep this joint stable. So the wrist joint stays stable. That's the whole purpose of this hand. And then you open your fingers like this, and then close. Open and close. So same thing, 10 to 15 times each time, 2 to 3 sets you can do for this. And the other very interesting exercise is a grip strength. So as you age, your grip strength decreases. You may have seen those stress balls. I feel like my dad and like my granddad always had this like ball on their like working table. I'm not sure if you guys have seen like stress balls, right? So with that, you can hold like grip that ball in your hand, press it as tight as you can, release. Press as tight, release. Again, 10 to 15 times, 2 to 3 sets. So this would really help with the full workout of your small joints of the hand. All right? Everything is demonstrated. You can list, you can read from there if you have any confusion, but that's pretty much how we do these exercises. I want to wrap up the talk, but I want you guys to take home a few messages from this talk. Firstly, it's all about preventing before treating. That's what we believe in and what we counsel our patients on. So just maintaining regular physical activity if you can, losing weight If it's applicable to you, if you know if your BMI is high or you're a little overweight or in the obese category, just making sure you lose that weight, eating the right foods, and these exercises. These are really key to a healthy joint. Another thing is that early recognition, if you're having these symptoms, that's key for you to, to prevent the arthritis from getting worse. So you're catching it early on, changing your lifestyle as we spoke about, and then obviously once you do have these symptoms, just be mindful of how you're treating it. Try the conservative therapies, the heat, the cold therapies, the massage therapy, Tylenol, Voltaren gel. If you really need it, you can take the ibuprofen for a few days. Be very careful if you're on another blood thinner, and if you start to develop any GI side effects, if you feel like any burning in your stomach, or any black stool, any blood in your stool, that's an alarm symptom. So always make sure to stop taking that drug and stop taking aspirin if you're taking, and then make sure to call your doctor. But try to avoid oral NSAIDs as much as you can. Unless you need them, take them for a couple of days, switch back to your Voltaren gel and Tylenol. Okay? Ideally, you wouldn't have to do this very often if you're eating the right foods and you're doing the right exercises. All right? Lastly, I want to leave you with some resources. I'm sure you guys have been here at the Sherwin-Level Center. It's a great resource for our community in Inglewood. Free exercise classes, still going on right now. Cooking classes, you can learn to make like healthy foods, make healthy choices. If you want to incorporate some exercise into your routine, this is a great resource as well. And then another one is I wanted to speak about is the Arthritis Foundation, New Jersey. You can Google that. It's part of a New Jersey chapter for arthritis. You can go onto their website, Arthritis Foundation, New Jersey, type it on Google, it's gonna pop up, go into the link, it's gonna connect you to your local group. And it's basically, they offer like groups where people with arthritis, caregivers of people with arthritis and families can have like a support group, and they can learn more about arthritis. And their programs include Walk with Ease. So it's like a walking program for arthritis, which you can be a part of, and you can have other people walk with you, just to make a hobby or like an activity out of it. And just don't feel like you're alone in this. Many people are suffering from this. So it's always good to have a community of people around you, and it gets easier when you know that you're not alone. All right. So that was it from us. If you have any questions, we are open to take them. Yes, please.
Thank you for the excellent presentation. My question is, what's the specialist, the doctor called that would treat this? What's his title, her title?
So you can go to your primary care doctor. Most primary care doctors are pretty much trained to managing arthritis. If it's not being managed, they can always refer you to a specialist, but you don't have to go to a specialist like right away when you have any of these symptoms. You can, if you're having obviously the alarm symptoms, it's best to go to your ED or call your primary care doctor if they're available at that time. But in terms of just managing arthritis and symptoms, a PCP is well equipped to even give you injections as well, if you need them, and just managing the other.
Yeah, but a specialist is called a rheumatologist.
Rheumatologist, that's like a bone doctor. Yeah. But you probably would need a referral for that from the PCP anyway.
One thing is that I was seeing orthopedic, and
Mm-hmm.
they see arthritis, they just like, they didn't deal with what I was suffering from. I had arthritis, and that was it now. That's what bothers me. Sometimes when you go to see the doctor, they see arthritis, and they say, oh, you have it, and that's it. They don't deal with, I had fallen on my knee in water in a restaurant. And once they saw the arthritis, that was it. Just, injections or suffering from. That's
So
my
the thing about that is, and I'll take your question after that. Doctors usually tend to treat osteoarthritis as a chronic illness, which it is. Just like you have high blood pressure, you have diabetes, you get control with medications. Osteoarthritis is usually treated in a similar way. There's things you can do to prevent the progression of it, symptomatic therapies. But if nothing is giving you relief is when, a higher level of intervention like surgery is opted for. So if you're saying you went to an orthopedic, the orthopedic is a surgeon. So they're thinking around it from the perspective if you need surgery or not. And they probably thought you did not need surgery. I hope that answers your question.
Just a comment on that. Yes, when you see that's the surgeon. That's what he's going to do. You might go though to somebody else like a physiatrist who is really more likely going to be working with like physical therapy
Yes.
for you. And again, everyone's different as to what it is that they need. But I know just for myself, for issues that I've had, I've gone to a physiatrist and they would, basically it was, if you need surgery, we'll tell you, if we analyze, we'll do x-rays, we'll check you out, and so forth. If you feel you need surgery, we'll let you know. But, many problems can be dealt with
Conservative
exercise, with
management.
physical therapy, that
Yeah.
kind of thing. And so he would push that more. A physiatrist.
So
So
if you look at the flyers as well, we've mentioned like specifically physical therapy rehabilitation.
Yes.
And what that means specifically is, like you very well pointed, is they're going to tailor make their whole regimen according to what your symptoms are and how you're feeling. So it's not going to be a one size fits all that everyone gets the same treatment. It's exactly what you need at that moment. And they're going to help you basically learn the exercises. You're going to go to them. They're going to teach you how to manage all your symptoms.
It's in the bigger handout,
Yeah.
not the brochure. Yeah.
They do when they're good for that, but you didn't prescribe.
So
So
physical
there-
therapy usually, the problem with physical therapy is that a lot of insurances, a lot of centers for physical therapy don't take insurance. So you have to pay out of pocket, which is why we wanted to do this talk, teach you the preventative exercises. But sometimes if nothing's helpful, you would have to go to physical therapy.
Yeah.
And a script would be given by your primary care doctor for physical therapy. You can try and learn those exercises which they tailor to your specific condition, and then you can always do them at home later.
Yeah.
But that's one thing with physical therapy. That's a lot of insurances. They do not cover it. Yeah.
Okay, now I'm upset. Dairy for inflammation.
Yes. Unfortunately.
Eggs,
I mean, you don't have to cut it out. It's more of everything in moderation.
Yes. So don't drink 2 glasses, 3 glasses of milk a day. Don't have 4 eggs a day. But everything in moderation, and maybe limiting, if you're eating, I don't know, a lot of carbohydrates, limiting it to like 2 to 3 servings a week rather than a day is what it really is. You can't cut out everything from your life. That's not realistic and it's not practical. But just trying your best here is what we need.
Basically, stay away from anything that tastes good.
Unfortunately. Unfortunately. Yes.
But I also find that if I'm having pains, if it's the knee or the shoulder or my hip, I think the power of the hand is great because I do my self-massage and I
Yeah,
For sure.
I feel relief.
Yes.
And then I might do something high, but the power of the hand, I think.
It is. It
Yes.
is. Massage therapy totally is a treatment for arthritis. So any balms that you have, I don't know, Tiger Balm or any balm that you like. Tiger Balm is mostly for muscle aches rather than joint aches, but anything that really makes the skin slippery enough for you to do a massage, that is good.
Yeah.
Swimming is something which we didn't speak about, but it also helps with arthritis. It's a full body exercise, removing like literally all your joints.
Yeah, and it's very low pressure on your joints, which is why it's recommended.
Yeah. All right.
Is tennis elbow associated with arthritis, or is tennis elbow is something totally?
So the medical term for it is called lateral epicondylitis, meaning you're kind of using it very frequently. Itis means inflammation. It's in the realm of it, but it's something that the second that you stop, using those maneuvers, it'll go away.
So just hot compresses, rest, immobilization for as much as you can. Those kind of things for that. But it's not arthritis, it's different. All right, so it's 7:12, 7:13 now. We'll wrap up the talk. We hope this was helpful and you'll utilize some of these strategies in your daily life. All right?
Thank you. Thank you.
Of course.